Good morning. Welcome to the Semel Grand Rounds. Today, I have the distinct honor of introducing just an absolutely treasured colleague, Dr. Kathy Lord. Dr. Lord is the George Tarjan Distinguished Professor of Psychiatry in the David Geffen School of Medicine at UCLA. She's a practicing clinical psychologist whose primary focus is autism and related disorders across the lifespan, from toddlers through adulthood. Her research and clinical work are aimed at improving methods of identifying strengths and difficulties in individuals with ASD and working with families and individuals to maximize independence and well-being for all concerned. This has involved the development of diagnostic instruments like the Autism Diagnostic Observation Schedule, the Autism Diagnostic Interview Revised, and the Social Communication Questionnaire that describe individual profiles of skills and weaknesses in carrying out longitudinal studies from age 15 months up to 30 years with the goal of identifying protective and risk factors that influence milestones of progress over the years. She's also very interested in graduate training for psychologists and other clinical researchers in ASD and related fields, and I can attest to her brilliance as a teacher and colleague. She's a member of the National Academy of Medicine and a fellow of the American Association of Arts and Sciences, as well as a former chair of the National Academy of Sciences Committee on the Effectiveness of Early Intervention in ASD. She's the recipient of numerous awards, including the Lifetime Achievement Award from the International Society for Autism Research, and she has over 300 referred journal publications and has been funded by the NIH, Autism Speaks, and the Simons Foundation for numerous research grants. And without further ado, I'll leave it to Dr. Lord.
Thanks, Ben. Well, it's very nice to be here. What I'm going to do today is to talk about the recent Lancet Commission publication and try to make this as relevant as I can to us and getting us to think about what does this mean. So let's see. I do have conflicts of interest, not really with this talk, but you should know that I do get royalties for diagnostic instruments and am working with a number of different companies to try to come up with better measures of treatment change. And what I'm going to do is talk a little bit about what the commission was, what we decided to prioritize, and then really 4 main points from the commission. And again, try to get us to think about, so what does this mean for us? So this was a very interesting experience for me. I had been the head of a commission from the National Academy of Sciences looking at the effectiveness of early intervention. And that was very organized. We had a program officer assigned to us and very set rules for what we did, and it was all Americans. And Lancet was really different because Lancet really prides itself, it's a medical journal for those of you who don't know it, that prides itself on its global reach. So we were supposed to be a global commission, and we were supposed to have people that represented all possible disciplines and all possible places. And sorting this out was a little bit like a puzzle where you're like, I need to find, if any of you have ever matched for research subjects, I need to find a redheaded 8-year-old boy with an IQ of 96 and to match my autistic subjects. So we also raised our own money. We were not paid to do this, so this was totally voluntary. But we had 3 in-person meetings, including one here, and ended up having 2 conferences, one here and one in London, where people talked about international aspects of autism. And then we divided into committees, and the committees outlined their sections after we had agreed what we were going to do. And then the whole draft, if people wanted to, was reviewed by everybody, and then 3 formal reviewers who were wonderful. We actually ended up making authors. Then we revised it, and then if any of you have ever had Lancet publications, they rewrite it, and then you unrewrite it. And it was launched in December. And they promised me that we will have hard copies of this sometime in the spring. Actually, I need to remind them. I'm also trying to write a plain language version of this, which has taken far more time than I thought, but I will try to do it. So we had members from 6 continents, 13 different disciplines, 32 people, including people with autism and parents of autistic kids, as well as advocacy groups. And the first thing we decided was we were really going to emphasize urgency. We're going to emphasize the idea that right, for the last really probably 20 years, at least NIMH and NIH have been very focused on basic science to translational science, and then hope that's going to solve all problems. And there clearly are people that do frontline intervention studies and things that are practical now, but it is such a small part of certainly the federal budget. And we really felt like people need to recognize this is a major issue. And when we see what's happened with, for example, the development of vaccines, we can do a lot if we decide we have to do it right away. But in autism, it's like, well, maybe I think we're giving up on the idea that genes are going to solve all problems, but it's still not clear what do we need to do. So that was our first priority, was to really emphasize that we need to do something now and not just wait for things to trickle down, the sort of Reagan economics of if you give rich people more money, everyone will have more money. If we give basic science more money, we'll all know more. I don't think that's true, even though if we weren't doing basic science, I would argue for them too. And the implication of that is that we need to know what works for people of autism, different ages, different levels, when, and how are we going to decide at what intensity? We don't even really know if 10 hours or 15 hours or 30 hours makes a big difference. We don't know if an hour a week, for those of you who've had to write recommendations, an hour a week of speech therapy is probably not enough, but we don't have any evidence that the child needs 3 hours. Where we started was the recognition that autism is a neurobiological condition. It does arise from biology, but that the clinical challenges that autism produces for people with autism and their families are not likely to be solved by biology. And so we decided that we were going to come up with recommendations that could be put into effect in the next 5 years. That was our limit. So trying to say not something that is going to take 10 years or 20 years or 50 years, but something that could be right now. So targeted research that can change lives right now. And I think one of the hard issues is right now we have a big push, for example, for implementation science and for stakeholder participation. We don't have a really strong evidence base about what works when for whom. And so we're implementing things that we might work with a particular population, but we don't even really know if they're going to work across populations. So that was our agreement. I think another major point that is completely obvious to you is that autism manifests itself very differently between individuals. And we're still looking for a recommendation that's going to work for everybody. We're looking for a screening that's going to find every kid, a diagnostic instrument that's going to find every kid, something simple that you can always say, like call your early intervention office or get ABA, but it doesn't work like that. And the differences between individuals are really become astronomical by the time that you get to teenagers and even older children and certainly adults. It's also that autism is different across the lifespan. People with autism develop. They're not the same all the time. And some people get better and some people take on other problems, which may in part be because of their situation of having autism, not necessarily the autism itself. So we need to recognize that this is a developmental condition and that people will require different intervention and supports at different times in their life. And I think we also wanted to recognize neurodiversity and the idea that people with autism have challenges and can struggle, but they also offer opportunities for work, for joy, for love, for happiness, for all kinds of things that we want to recognize. So I think out of this came the sense that we need a priority for large-scale research with immediate implications. And this is just something that doesn't exist at a very high level, for example, at NIH. You will find specific examples like Connie's HRSA study, but they are generally low budget, and not massive enough to really deal with the fact that we have these huge individual differences among people, and also that we also have big differences again over time. What that will require is also beginning to consider culturally appropriate interventions, because almost all the research in autism has been done with middle class, white, and sometimes to some degree Asian American, kids of well-educated families who have the time to volunteer or who seek out resources. And so we know very little about what actually works and what can make a difference for families who have fewer resources. We also feel like if we knew this, it would provide information for lots of other developmental disorders. And although we're all here, or maybe you're not here, but I'm here as an autism person, we do realize the boundaries between autism and other things are tenuous. And we can divide a line and say, well, you have autism, you don't, and we can agree on where that is, but that line could be many places. And there's huge overlap between people with autism and people with other neurodevelopmental disorders. So this isn't just to deal with the 2% of people who have autism, which is big enough. So one of the major things we came up with a lot of discussion about language and what do we really mean, is this idea of a stepped care, personalized health model for autism. And in the past, mostly when people talk about stepped care, they've talked about how can we provide the cheapest care that is most easily accessible to the greatest number of people. And it's often done from a financial point of view of how can the hospital or a health system reduce their costs and maximize who they give something to. But it's really not thinking about, is this going to work? What are the consequences of stepped care? And then the other thing that we felt like is that stepped care should not just be from the health system point of view of it's easier for me, for example, to tell you if you think you're depressed, for example, it goes on in England, to get on a web page and take the course for depression and then let me know if you're still feeling depressed. That's easier for me. It may not be easier for you or your family. And particularly thinking about the situations that families are in who may have quite difficult kids or all kinds of other issues that may not support a very simple answer at the start. So one of the things that we wanted to argue was that step care always needs to consider right from the start, where is the family coming from? Or if you're dealing with an autistic adult or someone who can speak for themselves, what do they want? We've learned, for example, I think trying to do studies where we provide medication and a behavioral treatment, that it's very hard to recruit people who want a medication into a study where they get behavioral treatment and don't get the medication for a while. It's also very hard to recruit people who want a behavioral intervention into a medication trial, even though many of us believe that often the two of the things would work, but it's very hard. And we need to think about that from the start. Not that families are always right, but that if we consider what a situation means to them, we're more likely to be effective. Then we also added the personalized health, not in the sense of precision medicine, where you're saying, okay, this is your genetic disorder, this is what we predict, but the fact that, again, people with autism are so different from each other, and we need to know, is this a child who has severe intellectual disabilities, major motor problems, and seizures, or is this a child who is very bright, but very defiant, and is causing all kinds of havoc in his family for very different reasons than the other child? I think the point of this, and again, I am an assessment person, so I probably am biased, is this means you need to know this before you start. We really should be finding out at intake about these things. And if we don't know, we need to find them before we start launching into making recommendations and directing people. And this is hard because not everybody can do everything. I think this is more than person-centered. I mean, there's been a huge push, particularly in education, to have person-centered meetings, but it's more than just saying you're in the middle, but it means we need to know about you and your family, and we need to be able to make some predictions of where you're going. And another issue, which is particularly an issue, I think globally, many of, for example, the Scandinavian countries, kids do get a very good assessment at some point and then never again. So they're shifted from medicine, where they get a diagnosis, often from a psychiatrist or sometimes a developmental pediatrician, to habilitation, which doesn't do assessments. And if you don't follow up on these things, kids change. So we need to be sure that there is follow-up and that somebody takes a step back from beyond just keeping track of what your treatment is to looking at how a child is changing or not changing, and an adult as well. So, okay, so the point of this all is that is just to give you an example of step care, and I don't know if you can see this, but the idea is the first column is just to decide what is it that you're trying to do. Why has a family come to see you? And I think with older kids, this is particularly relevant. With little kids, often families don't know. They just know something is wrong. And they often will say, look, if he could talk, he'll be fine, which is not necessarily true. But you're starting on the left. And this is an example of a 5-year-old child who is not talking in a lower resource country. So what would you do then? So you would figure out what's most important to the family, define goals for treatment, and you would begin to think of this before you actually even start the process. You're not going to say for sure because it might change. Then you're going to consider additional factors. So how old is this child? Maybe this child isn't even in school. And maybe one of the things you could do is to try to get this child in school, even if school doesn't really start until age 6. You need to know the severity of symptoms. Is this child toilet trained? Is that something that would be important to the family? Are they just assuming this is hopeless? Can this child feed themselves? And again, is that important to the family? So cognitive and language skills are going to contribute in something that you pretty much always need to know. And then safety issues. I mean, it may be for a minimally verbal 5-year-old, you're really worried about, for example, them just burning themselves if there are open fires or there are things that could hurt them. And those could be the priority. And in this case, for example, it may be the child's behavior at home because he's not even at school. Again, here we need to know who cares about this? Is this the grandparents coming in saying, fix my grandchild? I have a terrible daughter-in-law and she just is doing a terrible job. Or is it the parents who wants this and who is willing to work? Because I think we've all figured out that we can talk and talk and talk till we're blue in the face. And if families can't do anything, then we're stuck. In most cases, we can't change things very directly, except actually probably psychiatry to some degree with medicine. And then over here, we're going to look at accessibility and cost. But the point is basically all the cost to the health system, but also the cost to the family. So in this case, if the family, for example, you have 2 working parents, the child is with the grandparents during the day, you probably need to work with the grandparents at home. You need to figure out if you're going to see the family, when can you do it? And it's not going to be between 8 and 5. And they may not have access to telehealth. So the point is that you really got to think through these. And I think most of the time we do, but it's sort of after the fact. It's like after we have a diagnosis, after we have an IQ, after we're like, oh my gosh, this family can't do this. And so we want to front load that. This is an example, again, of a 15-year-old with high social anxiety, a child who's quite verbal in a high income country. So here we want to know, does this child come in with a million different diagnoses like ADHD and anxiety disorder? What are the priorities? Maybe this child doesn't want to go to school because she's so terrified and bullied. And what are our goals? And then here again, we're going to think she's 15. How do we get her out of the situations where she will be bullied? Most of the issues are happening at school. This is a child who has a lot of adaptive skills, but probably could do more. Maybe her hygiene isn't great, and that's something that people tease her about at school. And we need to think about what are her strengths and interests. Are there ways of giving her social contacts around the things that she's good at? Are there ways of protecting her a little bit from situations that are really painful, but giving her more positive things to do that she would actually enjoy? And maybe here, the parents really want medication and the 15-year-old doesn't. And we need to figure out, what are we going to do? You know, is it worth convincing the 15-year-old that medication could really help? And how will you do that? You can't just assume it, because she might take it for 2 months and then say, forget it, even if it's actually helping. And also the parents may be very dismissive of more behavioral strategies, whereas the girl might want them, or vice versa. So that's back to motivation. And then over here, we need to think about how, you know, can this family travel to get this girl to therapy or get this girl to a peers in person? Would it be worth it for them to travel to get this girl to peers? Maybe it would be. They will travel to see a psychiatrist, so that may be helpful. But this is going to require some effort, and effort on her part and effort on the family's part. And can they pull that off? So the point is just to think through this seriously. Okay. So I think then we're faced with, you have a model like this, and then you realize that 95% of kids with autism who are young have no services at all. I mean, or what's really likely to happen is their parents and families are doing something to help them, but they're in countries where there really aren't, you know, there's not ABA, there may not even be special ed. And so one of the things that it was really interesting in the committee was that we had some people who are very focused on US services, who said, for example, everybody who has autism in the US becomes a service user. And we need to think about how do we educate them and their parents as consumers to use things like early intervention and SSI and the various things that they can find. But then the people from the other countries who were like, what do you mean a service user? There's no services. So one of the things that the people from Latin America and Asia and Africa really wanted us to do was be very clear that people with autism need services and that they need to be identified. And although there's somewhat of a push, for example, in the step care model to not get too obsessed with autism only, the reality is that they feel like autism is discriminated against, it's stigmatized. The services, even for people with intellectual disability, for example, Down syndrome, often don't particularly want autistic people in there because they make more trouble. And so how do we compromise in that area? The reality is we're also very dependent on service systems. And I think I'm not going to change the service system, neither are you probably, but we need to be aware. And actually, I talked to Ben, who's in the middle of a service system, anything we can do to change service systems. For example, the impending idea that we can't necessarily use telehealth easily is a really important thing. And it is worth our time, even though it feels like that's not what I want to do. I want to see kids and families. I think the point of this slide is just that lots of things happen to kids with autism and families with autism. So we often start with overlapping, for example, perinatal complications. Prematurity is a risk for autism. So families are dealing already with a baby in a NICU and a tiny, tiny baby. We then get into school age, and kids, because they're reacting in different ways and have different experiences, it's not surprising that things are tough. They have atypical experiences which result in all kinds of issues, including anxiety and phobia. ADHD is certainly very, very common, probably more common than not in autism. And we also end up with frequently with learning disabilities. So it's very common in autism for kids to not be, for example, even smart kids to not be at grade level, especially for reading comprehension. And if you can't understand what you're reading, or you can't write, that slows you down very significantly in many ways. And then when we get to adulthood, we have all the restricted issues in economics. Very few people in autism are paid what they should be paid. Well, I should say have jobs that are equal to what they could have that result in them being paid sufficiently. And that is a huge leap. I mean, just getting people jobs of any sort is a major issue. But along with that comes anxiety and depression and frustration on everybody's part. So when we look back at what interventions do we have, and this is a paper by, I always say his name wrong, Sandbank, if you're interested, that just shows the, let's see, it shows the effects of early intervention. And so if we're to the right side of a line, we have effects. If it crosses the line, it's borderline. And if it's on the other side of the line, it's not so good. And this is just a meta-analysis of the data. I think the main point of this, though, is we do have effects. We have things that make a difference, but they're on the whole tiny differences. So they're small differences of like 7 IQ points, 10 IQ points, 5 words instead of no words. And that doesn't mean we shouldn't do them. I mean, if you've ever looked at your medication and it says, well, this, these eye drops were shown to reduce inflammation in 65% of people who took them compared to a placebo of 43%. You're like, great. That's, this is enough, but it's enough to warrant doing the intervention, but we can't relax. We can't say, okay, you're in Jasper, life is set, because good things are going to happen, but it has to be sustained. And we do have some really nice results with Cyclopharm for co-occurring conditions, but we need to know so much more. So where this all comes to is the point that we need personalized, targeted interventions over the life course. We do need to know about implementing these interventions, but we probably first need to know what is reasonable. And in order to do that, we need to move away from probably not a move away. We need to add studies where it's not my intervention and I study it and I try to prove that it's really good, because we have those. We could use those already. We need to move towards somebody independent doing an intervention that someone else has developed and comparing it to something else, or comparing doses, or comparing something about how it's given, and looking at having a large enough sample so you can look at who makes a difference. And that means a really big sample. And that's very hard, because if I'm trying to prove that my intervention works, I'm going to try to get a fairly homogeneous sample, because I don't want to include kids that I think are very unlikely to change. And I'm going to compare that to the sample that I think is going to have the least change, so my intervention will look as good as possible. Now, I do think Connie Kasseri is an example. She has done stuff which is not this, trying to compare one treatment to another, but it's been very hard to get out, to get that published, and to figure out what to do with it. And that's a whole problem in itself. We also do need to know cost effectiveness. So how much effort did it take? Did it take 6 months to train someone, or a year to train someone in the Early Start Denver model? That is a long time. And we need to hear from families and people who participate in these interventions. And we need to try them out with people that have fewer resources. And the problem there is that costs money. I mean, we did a study where we were trying to do early early social interaction, which is a parent-mediated treatment from Amy Weatherby. And we decided that we were doing this with any families we could recruit, but we were losing a lot of people who just couldn't hang on. And so we got money to study those families that couldn't do the ordinary treatment. It took 5 times our time to get those families into the intervention, to go see them on weekends, go see them at night. They canceled. We basically regrouped and added a component that was very practical to get the families to participate, as well as the parent-mediated changes. And we could do it, but it was 5 times as expensive as just saying, come on, middle-class mothers, and get in here. We also need to use more advanced research designs to be able to look at things that aren't just classic RCTs, because it's very hard to tell someone you're going to be randomized to a year of really great treatment versus something that we think is worse. And the problem is, and I think this is to some degree what Connie has felt, if you have equal treatments in terms of intensity and skill and motivation, you don't find much difference. And that's really, there might be subtle differences, but we need huge N's in order to see that. We need service systems that are more responsive and strive for continuous quality improvement. So not just to get something and then done. We need evidence-based interventions, and we need research conducted in less wealthy countries. The problem there is, again, it costs a lot of money. It's very hard to do research, and people tend to want to start from the ground up. They want to create their totally own intervention, which I think is really hard. I mean, having spent a lot of time creating diagnostic instruments, starting with 0 is much harder than starting with something someone else has already done and then saying, wait a minute, we need to adapt that. For example, one of the things they found in South Africa doing parent-mediated treatment was that the parents preferred to have somebody who wasn't from their village teach them as opposed to someone from their village, which is not what they expected, because parents felt like it was an invasion of privacy to have their neighbor telling them what to do. And I think we do not know all of those things. And so we need to know those things. But personally, I think funding things that are just completely come from the ground up is really wasting time, because we've already wasted so much time. And also then considering equitable access. And one of the things that our committee really talked about was this whole issue, because I think, for example, Autism Speaks has funded a number of ground up efforts, including one for having a checklist that anyone could use at any time with any age kid that would diagnose autism. And you just think this doesn't work even with upper middle class parents. What do you think this is going to work in rural Kenya? But I think we need to be sure that people can have control over what they do, but can modify stuff in a way that starts with something. So the second to last issue is profound autism. And this is something that's become quite controversial, which we maybe knew at the first, but I think one of the concerns is that people with autism who have severe intellectual disabilities and minimal language often get lost, particularly when there's a real gangbuster to we're full inclusion, everyone should get paid at least minimum wage, everyone should have, should not live in group settings. And sometimes it can be very helpful for somebody. I am not talking about institutions, but I'm talking about things like farms and things where you can't just have 3 people, or communities that are created. I think full inclusion is great if you can support it for most kids, but there are kids who don't understand what anyone is talking about and what are we doing if they are sitting through a 7th grade math lesson. So the committee felt like it was worth coming up with a term that described people who are likely to need 24-hour support throughout their lives. Now, this doesn't mean 24 hours of someone following you around, but it does mean essentially if you're living somewhere, someone has to be there. Even at night when you're sleeping, you can't have workers who go home and leave you alone in case you have a seizure or for some reason you decide to wander out of your house. So we defined this term and we had many, many discussions, and I'm not sure profound is the right word, but we didn't want to say severe because we think people can be severely affected by autism who are not intellectually disabled. And we didn't want to take that word away from them. And it doesn't, I will also say in other languages like profound in Spanish does not work. So there will be other words that people will come up for this group. So the other push behind this was that we think that people, when we're planning goals, for example, for school age kids and high school kids, often kids are still getting, for example, they're still learning ABCs when they're 10 and they have a 50-word vocabulary. And so it seems important to begin to think about where do you say this child needs other things? This child needs to learn adaptive skills. This child should learn leisure skills that are appropriate to him. We should be doing things that will make this child's life better for him, not just us. So we analyzed some data. For Lancet, we had access to 3 data sets. One of them was MOBA, which is a huge Norwegian epidemiological study following 100,000 births. So this is not focused on autism, but there are kids with autism in this sample. And what we were interested in was just how many kids would fall into the profound autism group. Because the kids in MOBA are now 10 to 20 years old. So they should be registered in the Norwegian system. And you'll see it's about 15%. Then the other thing we looked at was the proportion of females. And what's interesting is in all of the different samples, the red, you're comparing the red to the green, the proportion of females who fell in profound autism is higher than you would expect. Given the proportion in males. It's not that they're all females by any means, but it's just a different ratio. So we found in MOBA that it was about 15%, but we also found that there were kids that we knew from the beginning of MOBA when we were bringing kids in to assess, we knew had autism, who didn't end up getting registered as having autism. And I think it's partly because the registration comes through psychiatrists, and probably those kids are going to rehab. Are going to rehab and probably not even seeing psychiatrists because they were quite significantly intellectually disabled. So this is actually a lower count. SNAP is also an epidemiological study from the UK. And so they found about 22%. And then this is our longitudinal study. But in our longitudinal study, kids were diagnosed at 30 years ago. So really this is, and we have about 45%. So it just means that of the kids who got diagnosis 30 years ago, many of them at very young ages, many of them fell in this severe range. And then what's probably more important is just the proportion of females. And then the other thing we did was look at the stability if we placed these kids in, for SNAP and for our study, if we place these kids in profound autism at these different ages, how many of them still met the criteria as adults? And you can see it's 80 to 90%. So it's really, and the ones who moved out often got an IQ of like 51 when they were seen later. So they are not becoming typical people. So the point is that this is a stable category. We are not recommended that anyone has to use this. I mean, this is voluntary. And the point here is that at some point in later childhood, families should begin to be warned that this child is going to need care, and they need to think about where are they going to live, who is going to provide that care, and what's most important to this child. So this is just back to the organization of the talk. I want to end with a statement of hope. I think the good news is we know a lot, you guys. We know a lot about intervention, and we know a lot about what we can do to make life better. We need to work harder with services to make sure that those services are accessible. And probably I should be talking to the business school or public health. We know a lot about what autism is, and we know about the factors, for example, the co-occurring disorders and intellectual disability and language problems and ADHD that we need to attend to. I mean, I think when I started with LOVAS like 50 years ago, we didn't know any of that. No, we really had to convince LOVAS that we should do some kind of test, and we did horrible IQ tests. The point of this graph, which I really like, is the idea that if we can raise opportunities, that red line, then everybody gets better. And that there will be, I mean, there certainly will be kids who are not using resources who will get considerably better. But even high income kids who had everything under the sun, if we have job programs, you know, if we have more easy access, for example, to really good psychiatrists and potential psychotherapy and peers and things, we will move everybody up, and they're more likely maybe not to move out of autism, but just to have good lives. And that's the point. So I'll stop there and see if you guys have questions. I told you, you have to come up with good questions, guys.
Thanks, Kathy. That was great. So we will field questions both from the audience in person as well as over the chat. So if there are folks with questions, I'll ask for help in getting the microphone to them. And are there any questions here in the room? I can, while we get started, I can start with one of the questions from the chat. This is from Dr. Green. Hi, Kathy, wonderful talk. Like you mentioned, I do think it is a huge barrier for families to find and access services, even when they know there's a particular intervention they'd like. What kinds of efforts do you think need to happen to get these interventions more available?
I mean, I think the insurance mandate has helped with ABA. I think we're trying, I mean, I keep ending up on some state committee that I don't understand what I'm doing, but we keep saying we need to expand it beyond just traditional ABA. I think we need more training of providers. And I think we need to think about the whole issue, which comes with step care of task sharing. Like, I mean, I love doing clinical work, so it's really hard for me to ask someone else to do it, you guys. But I think the reality is we should be thinking about who could do this, you know, as well as me, that doesn't take an MD or a PhD, that would be cheaper. And can we get it funded? I mean, the crazy thing about the US health system is it's easier to get reimbursed, not enough, but reimbursed as an MD than it is to get reimbursed, for example, as a social worker or as somebody with a master's degree who probably would be quite good at running different programs. And so I think we need to think about that. I think we need to think about here at UCLA, we need to lobby for example, what can we do from telehealth and what can't we? I mean, I would attest you cannot do everything from telehealth, but you can also have pre-appointments with telehealth that save a lot of time when you're face-to-face and someone is dealing with a kid running around. So I think trying to think through how do we do that, and we need better reimbursement for psychiatric and psychological services. It's crazy the way the medical system reimburses people, and it's just a shame. Ben, there's a
right here. Yep.
Hi, thank you for this wonderful talk. I really enjoyed this global perspective because I think people forget that in low and middle income countries, it's near impossible to even get assessed. But actually, I had a question about something else, which was you just mentioned ABA, and it made me think of If you follow a lot of autistic self-advocates on Twitter, you must have seen the discussions that are ongoing right now. And the very, people who maybe can now speak because of the interventions they've had are now speaking up against, what they think is a torturous process and very vociferously, adamantly making claims about it. And I think this is a vocal minority, but I'm just wondering what you think is the path forward in this, debate, and how to, get a better understanding of what the concerns exactly are.
I worry about it a lot. I think that we have a group of very articulate self-advocates who have reasonable things to say. It just gets so overstated and it gets passed from person to person. And then people repeat it. I just was on a autism acceptance TV show, and there was a mother who was a social worker who had a 13-year-old stepdaughter, and she said, oh, we would never give her ABA because we know it's dangerous. And I was like, what are you thinking? I think people, so I worry about that. I also feel like the self-advocates represent a very narrow population, which tends to be well resourced, well educated, white, and I don't think that, and very adamant that they're speaking for everybody, which I just don't think is true. I was here in 1968, you guys, and we were not doing electric shocks, but I do remember a lot of us saying kids will learn faster if you slap them. And we all were like, yikes. As far as I know, no one ever slapped anyone, but he did say that, and it was awful. And we wasted a lot of time doing silly things, but we learned other things. And I think there's been a lot of, and that is not what ABA it should be today. There still is, there are people that do bad ABA and people who do good ABA. And ABA really just means using the things that we've learned from behaviorism about how someone learns, which need to be put in a context of who is this child? What are they interested in? What is harming them? What is not harming them? And what is important? So I think the concerns are valid to ask, but I also think that it's been so overstated. And I don't know the degree to which most of the people who are saying this actually experienced it versus are passing this from person to person. So I think it's something for all of us to be aware of, but it would be a real shame if we lost. And the fact that we can get insurance to cover something is so, that's a huge leap for even where we were, 20 years ago. It's so important. It's just that it should cover a broader range of things. And then again, we need to measure outcomes. We need to show this is really making a difference. And we need to not have to overstate, we're not talking about curing or making autism go away. We're talking about kids learning to understand what someone is saying, or learning to brush their teeth, or learning how to behave around another kid so that the other kid doesn't walk away.
I'll take another one from the chat. This is from Dr. Miklowitz. You made a great point about getting the treatment goals of families rather than relying on what we as clinicians think they need. What if a family believes treatment should focus on one priority, for example, education, whereas you as a clinician see the priorities differently, for example, family conflict or physical violence?
I think that's a really good question, and I'm not overruling the clinician. So I think, and I especially actually with little kids, I think parents don't know. They don't know what they're in for in most cases. And often the reaction is just, let's make this go away, which is not what you're wanting to do. But also I think, Kyle can testify, we have some families who have very different ideas about, what the kind of treatment that they want and what they want. I think you need to stick up for yourself as a clinician. So I think the point of all the list of things to assess is that you should start with asking the family what they want, but you also should be saying, look, I'm going to look at all these things about your family and the circumstances and your child, and then I'm really going to be the advocate for your child of what I think would make a difference. So I don't think you should. I think, well, we've recently seen a family who managed to get through like 6 different steps at UCLA, still thinking their child who was not essentially nonverbal is going to go to regular 5th grade as a highly verbal person. And I think the family conveyed that to providers who just couldn't make the point of, wait a minute, you know. And so I think we do have a responsibility to stick up for the kid ultimately, but at least listen to where the family is coming from.
We have a question in the room.
Loud.
Hello, Miss Majetti.
Hi. Can you talk more about in the step care model, like low motivated families and how you might address that if you think a kid really needs something that maybe the parents wouldn't be willing to do?
Yeah, I think that's a really good question. And I think part of my experience has been to be very concrete with families, set short-term goals. So you're not asking a lifetime, you know, you're not saying you're coming to therapy for a lifetime, but also focus on something that you think you can do in a short time so they can see that this is a result. And so that's where I would generally start. I think the other thing is to make sure that you see them enough. So, I mean, so that they keep coming back, because that can change. I mean, there are definitely families who have beautiful little 2 or 3-year-olds who it's just so overwhelming how cute the kid is, and how much easier it is to scoop them up or throw them in the air to make them happy than to make them do something. And so trying to pick, you know, what are the easiest steps for that family to do, and then also to check back in. I also think school, you know, if you can get families to get their child, if they're not in school yet, get them into some kind of organized group, then they partly they see the other kids, which is really important, and they may get feedback from people there, and the child may make gains. So I think those are my strategies, but it's a really tough issue. And I think it's a place where we need help culturally, because I think for me as a, you know, very, you know, grew up working class, middle class white woman, to be making statements to somebody that you need to do this, and you need to do that, you know, is not going to go that far unless I can show that this is really fits in with how families live.
I think we have time for 1 or 2 more. Would having a team with trained social workers or therapists help with the way autism is approached? Is there a way to ensure a comprehensive training where those from different cultural backgrounds can assist with the training to ensure effectiveness in treatment?
Yes. So I think when you get a really good experienced social worker involved in case management, it is a wonderful thing. I think the hard thing, and we know this from CAN, is struggling to find somebody like this and get them paid. And my experience has been having someone wonderful and then they're snatched away by a private practice that is much nicer to them than the university is. And so I do think that it's really important. I think it is also important for people to be trained. I think the hard thing is you could come, just like you could come out of a PhD in psychology or psychiatry and not know much about autism and throw them in. And then you're like, why aren't you dealing with this carefully when people don't know what they're doing? So I think some training really helps. And I'm not sure, I think many times that training is person to person. But it's if you don't get the first person, you know, then how are you going to do it? And I do think that the cultural awareness makes a huge difference. Huge. There's a, I think, oh, okay.
Hi, thanks for a great talk. I was curious if you could speak to your view of cases that wind up needing to be placed out of the home, and whether you, for example, view that as treatment failure over time, or how you think about situations usually later in life or adolescence when families have wound up in a situation, or even the healthcare system, where they're now considering things like long-term placement of them.
Yeah. I mean, I don't know if it's a treatment failure. I think everybody feels like it's, we all feel like we failed when that happens. But I think it's probably better sooner than later. I think what I keep saying to the students I'm working with is that some of these families just hang on until something awful happens. Somebody gets hurt, really badly hurt, or parents have a stroke, and then everything falls apart. So I think if there were better ways for us to get even longer term, like respite care, where we say, look, we need to figure this out. I think that would be better. I mean, it's never the choice. And I think, obviously, like being hospitalized hospitalized can help sort out what's going on, but being hospitalized does not help when you go home. And so we need like step care models out, like day patient programs, and then things where the families could ease back in. So I feel like it's not a good end, but I also feel like I've got a couple patients where I'm just waiting for things to get worse because it's so crazy, especially after COVID. Families who've got their kids home all the time, and everyone is hurting everyone, and they're just waiting for the kid to hurt the sibling, or something really awful to happen. And I've seen it enough to know it does. So I think we shouldn't say this is abject failure. It's if we could plan it, it would make more sense, just like, elderly spouses and planning, assisted living, which sounds awful, but I think it's, and a plan of the way in and a plan of the way out. It's a good question.
I want to apologize to those with remaining unanswered questions, but I made a promise
Okay.
that we were going to stop on time for you, Kathy. So thank you again, everybody, for joining both virtually and in person.
Thanks, you guys.